Hello, I'm Dr. Michael Niederman, Professor of Clinical Medicine at the Weill Cornell Medical College in New York, as well as Associate Chief and Clinical Director in the Pulmonary and Critical Care Division. Today, I'm going to discuss with you where should we focus future research on COVID. This is an extremely exciting topic and one where we've seen tremendous amount of new information and growth in a relatively short time. In the springtime after COVID first began, I co-authored an editorial in the Blue Journal with several other investigators to speculate on where we needed the most amount of information going forward on COVID. It was clear we needed to understand disease spread, particularly spreading a virus from asymptomatic individuals, which required a better understanding of the incubation period and the period of spreading. It was clear we needed to understand how long to quarantine people and whether quarantine would be a good thing or a bad thing, and if potentially doing group cohorting for quarantine might actually spread the disease. We were interested in defining the optimal methods to slow disease spread. We've certainly learned that social distancing and masking are key factors in slowing disease spread. We would like to know how much herd immunity is required to slow down pandemic spread. And I think we've realized that nobody yet has developed herd immunity. We would like to develop biomarkers to identify which individuals are most likely to become severely ill, and particularly to identify the presence of bacterial infection, either as a complication of the initial infection or as a superinfection in mechanically ventilated patients. There are a number of clinical trials that were needed about medications that included remdesivir, antibodies directed at the virus, hydroxychloroquine, IL-6 inhibitors, JAK inhibitors, and there were a number of drugs that are currently available that needed to be studied and see if they could be repurposed, most notably corticosteroids. We wanted to define exactly when antibiotics should be used. We wanted to find ways to minimize the psychological stress on the healthcare workers as well as on the patients and families. We wanted to understand the best management of patients, when we could do telemonitoring, when we would have to do live visits, how much individual patient contact was needed to give optimal care. And ultimately, we wanted to find the best strategy for ventilation. When do we intubate patients? When can we use non-invasive ventilation, high flow nasal cannula, and when can this be done safely? All of these were burning questions just a few months ago, and for many of them, we're already getting guidance. We're not having all the answers, but certainly getting guidance. For example, this study from the Annals of Internal Medicine very nicely documented that the average period between the infection and onset of symptoms is about 5 days as the typical incubation period, but it may require as long as 11 days before everybody manifests symptoms. And this has led to some of our recommendations for how long to keep patients in quarantine after an intense exposure. We also have begun to identify the risk factors for severe disease. In this study from New York of over 5,000 patients, where 87% of patients had one or more comorbidity, what we saw was the most common comorbidities were hypertension, obesity, and diabetes. And if you look at the case fatality rate, it related to specific comorbidities. In this early series, they had a mortality rate of 49% in critically ill patients. In our hospital, fortunately, our mortality rate in critically ill patients has been lower than that. But the other comorbidities that were important included age greater than 80 years, cardiovascular disease, and diseases like diabetes and chronic respiratory disease had a slightly lower risk, but still a substantial risk for severe disease. We know that some of the clinical predictors of disease severity include relatively low IgG to SARS coronavirus 2 in severely ill patients, but there are a number of biomarkers that are characteristic of the disease, particularly with more severe disease. For example, an elevated D-dimer, an elevated IL-6, an elevated C-reactive protein, an elevated ferritin, an elevated lactate dehydrogenase, and there's actually a reduced lymphocyte count and a reduced hemoglobin, also as markers of disease severity. High levels of procalcitonin seem to be related to prognosis, and low levels may mean that there's no concomitant bacterial infection. In this series of about 200 patients from China, when there was a procalcitonin less than 0.25, there was no bacterial infection, and among individuals with a procalcitonin greater than 0.5, 25% of non-survivors had a level that high. It was relatively rare to have a level that high in survivors. And similarly, what we've seen in another large series from China is that most patients have an elevated C-reactive protein, but relatively few have an elevated procalcitonin. 5% with an elevated procalcitonin versus 60% with an elevated CRP, making it clear that CRP is a better prognostic indicator of inflammation, whereas procalcitonin may be a better prognostic indicator of infection. In individuals with COVID, again, in this series, many had fever, but very few had elevated procalcitonin. Many had an elevated C-reactive protein. And so these differential biomarkers may help us understand who's likely to have infection with bacteria and who's not. And again, more studies are needed to clarify this. We also know that secondary bacterial infections, and particularly ventilator-associated pneumonia, can complicate COVID. And in this study of nearly 1,000 patients from Barcelona, there were 44 patients who had hospital-acquired infection. And in that group, 11 of them were ventilator-associated pneumonia and 4 were hospital-acquired pneumonia. So we certainly know that individuals with COVID on mechanical ventilation can develop nosocomial bacterial pneumonia. Early on, we looked at COVID as a hyperinflammatory state, and we had this concept of early infection in the first week being due to viral replication and viral response. Later, there's the host inflammatory response after about a week, and it begins to rise. And then there's a hyperinflammatory response much later. And we were conceptualizing that here we would need antiviral therapies, and here we would need anti-cytokine therapies. And although many studies have proceeded under these assumptions, one important new observation has been that it may not be a cytokine storm, but a bradykinin storm that's responsible for the altered vascular permeability and the hypotension that some of these patients get, and that the lungs may be filling with pulmonary edema that's rich in hyaluronic acid hydrogel, and this may account for some of the differences we've noticed in lung compliance. Although most patients with ARDS and COVID have stiff lungs and classic ARDS, there are some patients who satisfy the definition of ARDS who don't really have such stiff lungs, and maybe, again, this hyaluronic hydrogel initiated by bradykinin storm may be in part responsible. We've also known for a long time that there are pharmacologic therapies, and many of these have been studied. We've looked at repurposed drugs like hydroxychloroquine, not showing tremendous benefit. We've looked at lopinavir, ritonavir, again, not tremendous benefit. We've seen no impact of ACE and ARB drugs that are used commonly for hypertension. We've seen remdesivir in the United States be widely used now early in the course of infection, and corticosteroids as anti-inflammatory adjunctive therapy may have a role, but we've seen studies now of anti-IL-1 and anti-IL-6, and we've looked at COVID-specific immunoglobulins also having a role. IDSA has recommended treatments that include remdesivir and glucocorticoids. Remdesivir is currently now recommended for hospitalized patients with severe COVID, and the greatest benefit may be in more severe COVID and in individuals on supplemental oxygen. 5 days of therapy appears to be almost as good as 10 days, or really equivalent to 10 days. Glucocorticoids, based on the large recovery trial, shows that dexamethasone at 6 milligrams per day for 10 days is effective for more severe COVID, meaning individuals who require supplemental oxygen or mechanical ventilation. There's an ordinal scale for COVID recovery that goes from not hospitalized to death on an 8-point scale. And this has been a major advance in clinical trials because clinical outcomes have been evaluated on this ordinal scale. The simple moderate trial of remdesivir showed that for mildly ill patients, 5 and 10 days were equivalent to one another. And of course, the recovery trial of dexamethasone was a landmark study that showed that when you looked at individuals across the board, there was a benefit for survival in those given dexamethasone, but in those who were not on oxygen, there was actually a trend for patients to do worse with dexamethasone than with usual care, whereas in individuals only on oxygen, and particularly in those on mechanical ventilation, the margin of benefit with dexamethasone was much greater. Currently, the IDSA recommends that certain treatments should only be used in clinical trials. Those include hydroxychloroquine, lopinavir, ritonavir, tocilizumab, convalescent titer, and famotidine. And of course, the future is very focused on vaccines. There are a number of vaccines that are being studied. They're being targeted at RNA itself. There's some that are being targeted directly to the spike protein on the virus, and there's some that are being targeted to the virus as a whole. So there are many questions now that remain about vaccines. Do we develop a vaccine against RNA specifically or against the whole virus? Will a vaccine have to be a single dose, or will we need booster doses? How long will the immunity last? And will the immunity protect against a natural infection? Many of the trials are documenting the presence of antibodies, but we don't know if those antibodies prevent against a natural infection. Also, we'd like to show efficacy to an unvaccinated group, but now the unvaccinated groups are having a lower rate of infection than months ago because they're using masks and social distancing. And finally, what about vaccine safety? In the past, with the swine flu vaccine, we saw the development of Guillain-Barré syndrome, which was quite alarming, and we'd like to see that the current vaccines don't have that degree of neurologic toxicity. And as you know, there was an early signal in one of the trials of a possible neurologic complication. So I think there's a tremendous agenda to move forward, developing new therapies, better prognostication, developing vaccines. But the thing that strikes me, and that's remarkable, is if you look at that list that we developed just 6 months ago, many things on that list have been addressed, and for many things we have an answer. So I would say progress is rapid, but it needs to continue, and we need to be on this light speed movement towards managing this disease. So again, I thank you for your attention. This has been a wonderful conference, and again, I thank you so much for being part of this conference, and I look forward to our discussion. Thank you.